Let's get started. Welcome, everybody. I'm Christy Russell. I'm Senior Medical Director at Genomic Health, and I'm quite pleased to introduce Virginia Kaklamani, who is Professor of Medicine at University of Texas Health Sciences Center, San Antonio, and as you know, she's one of the coordinators of this symposium, and she will be speaking today on managing estrogen receptor positive, HER2 negative, early breast cancer patients with recurrence score under 25. Virginia.
Well, thank you all for spending your lunchtime with us today. We actually have some really interesting data that we will share with you. Obviously, some of the data is going to be coming in the next few months, but some of the data that was presented at ASCO that I think will help you practice in clinic with your patients. So obviously what we know is that for the longest time we have been using clinical data to decide how to treat our patients, whether to give chemotherapy or not, and also clinical data to decide what a patient's prognosis is. When we look at the Oxford Overview Analysis, that presents us data from several studies, randomized clinical trials being presented, but that data has been looking at factors such as age, nodal status, size of the tumor, grade of the tumor, to help us figure out what a patient's prognosis is and whether chemotherapy is needed or not. But what we've recognized is that we can do better than that. We can do better by characterizing the tumor and looking at the genomic makeup of that tumor. So when looking at different prognostic and predictive factors, the prognostic factors that we all kind of agree on obviously is nodal status, tumor size, HER2, ER, and PR status. And we have genomic assays, not only Oncotype DX, but several other genomic assays that have very solid prognostic data. Prognosis is great. It's very good to be able to tell your patient, you know, this is what I think your risk of recurrence is. This is very useful information. But it's useful information if I can also follow it with, and this is what I can do to decrease that risk of recurrence. And this is where prediction comes in. Predictive factors in adjuvant therapy have to do with the ER and PR status, HER2 status, and really the only genomic assay that has predictive data is Oncotype DX. And I will share with you some of that data, although I know that this group, you are all familiar with many of that data already. What is important to recognize, and this is something that we've seen with Oncotype DX over and over again, is that there's a continuum in risk. Risk is not yes or no, patient has a low or high risk, but it's really a continuum depending on what that recurrence score is. The lower the recurrence score, the lower the risk of recurrence. And then we somehow have to figure out in our minds what we consider low risk, what we consider intermediate risk, and what we consider high risk. When the initial data came out as far as prediction with Oncotype DX, that was all based on NSABP B20. And although this is a busy slide, what is interesting in the left part of the slide is looking at the curves of chemotherapy benefit in 3 different groups. A low risk, meaning a recurrence score of less than or equal to 18, or less than 18, a recurrence score of 18 to 30, which is the intermediate risk group, and then a recurrence score of 31 and more, which is the high risk group. And obviously, the important thing in this slide is that when we look at the red and dotted red lines, that is the benefit of chemotherapy in this high risk group, which is 28% absolute benefit, much, much higher than we ever thought chemotherapy would give us. High enough that when you look at all groups together, this one group that is around 25% of our patients explains the chemotherapy benefit in every single patient with early stage ER-positive breast cancer. But what also is important when we look at the right side of the slide, the bar graph, is to look at these risks in a little bit of a different way. So the red bar is our high-risk patients. And here you can see the absolute benefit from chemotherapy of 28%. It's very clear. The green bar, which is our low-risk patients, the confidence intervals are very, very, very close. And you can see that there doesn't seem to be any benefit from chemotherapy. The yellow bar, even though in our initial analysis there didn't seem to be any benefit from chemotherapy, when you look at the 95% confidence intervals, there's a concern that there's a subgroup of patients, hopefully this will work, won't work, but there's a subgroup of patients where there might be a benefit from chemotherapy, and that is in the subgroup where the 95% confidence interval is above 0. So this has always raised concerns with us as clinicians, because if you have chemotherapy available, the worst thing you can do is not offer it to a patient that really will benefit from it. At the same time, you don't want to be giving chemotherapy and giving the toxicities from chemotherapy to patients that will not benefit from it. So how do we reconcile those two? And again, we keep in mind the fact that there's a continuum in risk. The lower the score, the lower the risk. The higher the score, the higher the risk. But in this intermediate risk category, there's a patient who has a much lower risk and a patient that has a much higher risk. And so in this intermediate risk group, it's still a little bit of a struggle as to whether we should be grouping all those patients together and whether we should be giving the same recommendation to a patient with a score of 18 and a patient with a score of 30. And another way to look at the data, you look at this intermediate risk group where on the left side, you're looking at the graph of patients that received and did not receive chemotherapy, and there's no benefit. But when you look at the right side, and this is again a little bit of a busy slide because it includes the 95% confidence intervals, but if you focus your attention on the blue and the yellow solid curves, you will see that the higher the recurrence score, the more the benefit that we get from chemotherapy. And in this intermediate risk group, right maybe after 25 or so, you're starting to see those curves increasing in what we think is probably a clinically meaningful improvement with the use of chemotherapy. How about node-positive patients? Now we have one clinical trial, S8814. Remember that this is only in postmenopausal women, so this is one of the limitations of the data that we have in node-positive disease. And it's relatively clear that in patients with a low recurrence score, there's no benefit from chemotherapy. Very clear that in patients with a high recurrence score, there's a benefit from chemotherapy. But when you look at the curves in the patients with the intermediate risk category, again, doesn't seem to be a benefit from chemotherapy. So the node-positive data is very similar to the node-negative data, with the limitation that this is in postmenopausal women as of now. Now, we all know TAILORX, and we have been eagerly awaiting for the data. But what data do we have already? And just as a reminder, this is a huge clinical trial. We accrued more than 10,000 patients on the trial. And there were 3 groups. Now, the risk groups were different from what I just shared with you. So the low risk was 11, the intermediate risk was 11 to 25, and the high risk was 25 and more. And I'll explain to you why. So the low-risk patients all got hormonal therapy, and we do have the data for that I will share, published in the New England Journal a couple of years ago. The intermediate risk group is where we have the bulk of our analysis happening, and this is the group that we're waiting for data. And then the high-risk group is the patients that all received chemotherapy in combination with endocrine therapy. So the primary study group, which includes 6,800 patients, is the intermediate risk group, randomization to chemotherapy and endocrine therapy versus endocrine therapy. So why did we come up with these groups? We came up with these groups because we looked at the upper limit of the 95% confidence interval. And if you talk to someone and say, what do you think is a low risk of a patient having a recurrence? And most physicians will say 10%. So 10% is right at 11, which is why patients with a recurrence score of 0 to 10 on TAILORX and many of the subsequent data are considered low risk. Then you ask physicians and say, well, what's your risk of a high recurrence? And people will say 20% or more. And so the 20% of that, the higher 95% confidence interval is a score of 25. So this is why the score of 11 to 25 was selected, based on the 95% confidence interval in the B14 trial. So the primary study group, which was the 11 to 25, was the one that was going to be and is going to be studied. We're still waiting for data. But the good news is the more we wait for data, it means that we don't have enough events. If we don't have enough events, it means that patients are doing really well. And if patients are doing really well in both groups, it's relatively unlikely that we'll find differences with the addition of chemotherapy. But obviously, we don't have that data yet. So there's stratification factors. One thing that I want to point out, because I know once we get the data, everybody will say, well, yeah, but what if my patient has a 22 score? What if they have a 24 score? What if they have an 11 score? And we actually are breaking it down into smaller score categories. So we will have data on a recurrence score of 11 to 15, 16 to 20, 21 to 25. So for a patient that has the upper limit of that intermediate, we will still have an answer as to whether we think chemotherapy will benefit that patient or not. When looking at the patients that were included in the Arm A, which is the low-risk patients, and the Arm B and C, which is the intermediate-risk patients, they had very similar characteristics. So the median age was mid-50s. We had around 30% premenopausal women. Tumor size was relatively the same. Intermediate histology was relatively similar in both groups. So a relatively balance between the low and the intermediate risk groups, which also tells you that it's probably relatively hard with clinical characteristics to tell whether somebody has a low risk or an intermediate risk based on Oncotype. And the data that was presented and subsequently published in the New England Journal shows that the patients with the low-risk group did exceptionally well. Obviously, none of them got chemotherapy, but I don't think that you would want to give chemotherapy to any of these patients. You're seeing a risk of distant recurrence of 0.7%. So how can you ever improve that with chemotherapy? When looking at all of the other factors, all of the other ways of measuring recurrence, patients did exceptionally well. Overall survival, 98%. Invasive disease-free survival, 93.8%. And then distant relapse-free interval, again, 99.3%. So this is a group of patients that does exceptionally well without the use of chemotherapy. But are there other factors that can help us figure this out instead of us having to order Oncotype? And the answer really is no. When you look at the age of the patient, there was no difference. When you look at tumor size, there was no difference. Tumor grade, and I hear a lot about tumor grade, there didn't seem to be any difference. So we can't rely on these clinical factors anymore. We know a lot more. And that's why it's important to look at the genomic assays for prognosis, not look at the pathologic factors. Now, looking at real-world data, we don't have the results from TAILORX yet, but what do we have to help guide us? Because we are ordering Oncotype, we are getting scores of 18 and 22 and 25, and do we know what to do with these patients? Do we know whether we should be giving those patients chemotherapy or not? So there were a couple of studies that were presented at ASCO this year. One was an Israeli data set. It's called CLALIT, and it's a data set that accounts for around 60% of patients treated in Israel. They do the Oncotype DX assay routinely, and then based on that, they decide on whether to give chemotherapy or not. So this data was collected prospectively from 2006 and on. And when you look at the different variables that they had on the study, they had a little over 2,000 patients. Median age was 59.3, pretty normal for breast cancer. The majority of patients had node-negative status. The grade of the tumor was evenly divided. Size of the tumor, mostly smaller tumors. Only 22% of tumors were over 2 centimeters. recurrence score was balanced similarly to how we see it in the United States. So half of the patients had a low risk, 40% of the patients had an intermediate risk, and around 11 or so percent of patients had a high risk. And then the chemotherapy use, as you would have expected, was higher in the high-risk group, almost none in the low-risk group, and around 25% of patients in the intermediate risk group received chemotherapy. And obviously, the higher the recurrence score, the more the chemotherapy that patients received. That all makes sense. That's similarly to how we practice in the United States. So how did these patients do? Now, on this data set, the Oncotype DX, for probably the millionth time, was also found to be a prognostic assay. So you have the patients with the high-risk group, and again, this is 31 and 18 as the cutoff points, and those patients did not do as well as the patients in the intermediate or low-risk group. But when you look at the patients in the intermediate and low-risk group, they did very similarly. This intermediate risk group of patients did exceptionally well. And when you divide it into the more modern division, the 11 and 25, again, you'll see that the events in the patients with the score of 11 to 25 were very, very few, 1.3. So obviously, when you have a risk of recurrence of 1.3 in 5 years, it's pretty hard to make that better by giving chemotherapy. We still don't have that data, but this is pretty suggestive that you can identify a group of patients with a score not just less than 18, which is what we did before, but less than 25 that are not going to benefit from chemotherapy. Now, the other data set that actually has even more data is the SEER data set. And this was again presented this year. Now, SEER, obviously, large data set of individuals getting treated for many diseases, including cancer. The patients were captured between 2004 and 2011. Initially, 379,000 women. When they looked at the ones that had a recurrence score, that was 46,000. Patients that were hormone receptor positive and HER2 negative, 45,000. Node negative, 40,000. And then they looked at ages between 40 and 84, and they came up with 38,000 women that were included in this data set. So a pretty large data set of prospectively collected data in women that were node negative, ER positive, had an Oncotype score. So 38,000 women. So with 38,000 women, you can do a lot of things. Again, we're showing that Oncotype is prognostic. The higher risk group patients did worse than the intermediate and the low risk group. But again, the intermediate and low risk group did relatively well. Now, how about chemotherapy? And this is kind of the interesting set of data, and I'll show it to you in a few different slides. But when you look at whether patients received or did not receive chemotherapy in the different groups, you're seeing that the patients in the intermediate risk group did actually pretty well, regardless of whether they received or did not receive chemotherapy. And again, this is an intermediate risk group of 18 to 31. The use of chemotherapy, the same with the Israeli data, was higher the higher the Oncotype score. No surprise here. Now, the primary objective, obviously, was to look at invasive breast cancer, looking at TAILORX recurrence score cutoff points. So not the ones that were originally set at 18 and 31, but the 11 and 25. And again, there we had around 49,000 women in the SEER data set. And you can see how everything was stratified. Recurrence score less than 11, 11 to 17, 18 to 25, 26 to 30, and over 30. And this is really, as a clinician, that's kind of what I want. I want to have the power to be able to look at those little subgroups, because I have patients that will have a score of 19 and a score of 20, and I don't want to be quoting them data from a recurrence score category that's 18 to 31, and they're in the lower category. But if I'm able to make those subsets even smaller, I feel more comfortable about the data that I'm presenting. Again, this is a continuous biology, and the higher the score, the higher the risk of recurrence. We all know that. And when we look at, again, chemotherapy use, it has to do with the score. The higher the score, the more chemotherapy you're using. And you see now with the different risk categories, the less than 11, 11 to 17, 18, 25, 26, 30, and 31 plus, you're getting more chemotherapy. You know, interestingly, there are patients, it's 3%, but I wonder what that 3% of patients is with a score of less than 11 that's still getting chemotherapy. But thankfully, it's only 3%. So when you look at all of these categories, you can see again that this is a prognostic assay. The patients with a score less than 11 are doing exceptionally well. But you can't even see the curve from 11 to 17 because it's superimposed with the less than 11 curve. Those patients are doing identically. And when you look at the patients in the 18 to 25, which is the solid yellow curve, they're doing almost as well as the patients from 11 to 18. Now, where you're seeing the differentiation is the 26 to 30 and over 30. And I think this kind of helps validate why TAILORX picked those cutoff points and not the 31 and 18 cutoff points. How did they do with chemotherapy? That's the million-dollar question, right? So when we look at the high recurrence score patients, the 26 to 30, 30, 31 plus, you're seeing a benefit from chemotherapy in both of those categories. Again, glad that TAILORX picked the cutoffs that they did. So 26 to 30, there's some benefit. It's significant, marginally significant, but significant. And over 31, there's a clear benefit from chemotherapy. And I know that this is a busy slide, and I will show it to you in different subsets, but what you'll see here is that the only groups that got the benefit from chemotherapy was at 26 to 30 and 31 plus. All the other groups did not get a benefit from chemotherapy. So breaking it down into the first three groups, which is really our interest, what you'll see is obviously with patients with a recurrence score of 11, of less than 11, they had no benefit as whether they got chemotherapy or not. The patients that received chemotherapy were in the red bar. The patients that did not receive chemotherapy were in the blue bar, and you're seeing identical. But the same is happening with the patients with a score of 11 to 17, and more importantly, 18 to 25. Prospectively collected data, 48 or so thousand patients. We're now having the power to look at the subgroup of patients with a test score of 18 to 25, and the patients that got chemotherapy had no benefit from it. So this is pretty good data, especially coming up to the TAILORX. But I think based on this, even now, it's kind of changing my standard. I used to give chemotherapy to many of those patients, and now based on this data, I don't know that I will be offering it as much. Obviously, again, we want to wait for the TAILORX data for more definitive data. And then looking at the other subgroups, it becomes clear that we do want to give chemotherapy to the higher risk patients. The benefit that they are getting is relatively good. Now, obviously, they get more benefit if they have a score of 31 or more, but even in the recurrence score category of 26 to 30, you're seeing the two curves, the blue and the red, they're starting to diverge. So in that group, we probably will have some benefit from chemotherapy. Remember, the TAILORX study did not look at that, so that we won't have any more information from that subgroup of 26 and up on TAILORX. So this is really the best data we're ever going to have that tells us whether to give chemotherapy to patients with a recurrence score of 26 to 30. So I think based on all that data, what obviously we know that Oncotype DX is a prognostic assay. We have a lot of other prognostic assays. I would not use Oncotype DX for prognosis. I would use it for prediction. It is a predictive assay, and it helps us not only in the high-risk patients over 31, but with this newer data, it helps us with other subsets of patients in this intermediate risk group. And I think it gives us pretty good data in the patients from 11 to 25 until TAILORX is presented to avoid chemotherapy in those individuals. Now, TAILORX hopefully will have some data beginning of 2018. Every 6 months or so, the statisticians are looking at the data to see if they have enough events. I guess it's a good problem to not have enough events because it means your patients are doing really well. But regardless, we will have data soon. So I want to thank you with that and take some questions and comments. Thank you.
Oh, that was excellent. A clinical question is, do you factor in, besides the OncoDX, and I'm talking between 18 and 25, if you have a young patient, larger tumor, lymph node negative, other bad factors, 45 or a 50-year-old, how do you factor that in?
I really don't. When you look at all of the data that we have seen with Oncotype DX, a multivariate analysis that includes all those factors has found that all those factors lose their significance, and the only thing that continues to be significant is Oncotype DX. I think where I take those factors into account is whether I will order or not order Oncotype. So if I have a very young woman, a 35-year-old, I may say, you know what, I don't feel comfortable getting Oncotype. We do have data on Oncotype in younger women, but I don't know that we have enough in that intermediate risk group. So I may say, I'm going to give chemo to that patient. But if I decide to get Oncotype, that's what I look at. I don't look at any other factor to make me decide whether to give chemo or not to the patients.
Thank you. This is really interesting. So what you're showing is node negative. So suppose now you have your postmenopausal with one positive node with a score of 25. What are you doing today?
So we have the RxPonder trial, S1007, that has accrued, and we're waiting for results. And because this is a node-positive group, we're probably going to have it relatively soon, although we thought that with TAILORX and we didn't. So the node-positive data, the majority of that node-positive data is in patients that are postmenopausal. Now, there will be a poster presented here tomorrow looking at that subgroup. And it looks like the data is very similar to the node-negative patients. So based on that poster, and this is from the SEER analysis, you may be able to avoid chemotherapy in that group as well, because now you'll have two sets of data in node-positive patients.
So my patients that I saw last week who has this situation, how would you treat her on Monday when I go back?
I would ask you to look at that poster and decide yourself. But having seen some results of it, I would probably not give her chemotherapy.
Thank you.
Thank you. Thank you all so much. I appreciate it.